I'm going to reconstruct May 1 to 2 minute by minute, focusing on the hemoglobin drop, suspected bleeding, transfusion timing, physician notifications, pressors, labs, and the code blue. I'll separate what the chart explicitly documents from gaps or delays that need expert review. I found an important detail that strengthens the timeline. The nursing flowsheet documents bloody gastric OG tube drainage starting at 2:18 a.m. before the 2:50 a.m. GI bleed consult order. That means the chart appears to show objective evidence of bleeding early in the morning, not just a later suspicion. Yes. I went back through Richard's extracted hospital records and reconstructed the most important sequence I can verify. There are several things here that I believe deserve very serious review by an independent ICU critical care and GI expert for possible delay in recognition or treatment. I cannot legally conclude malpractice from the records alone, but this timeline raises significant questions. May 1st, 2026, 11:19 a.m. Hemoglobin 9.2 grams per deciliter, hematocrit 28.4%, platelets 142, WBC 16.3, lactic acid 6.2. Richard was already critically ill. Around 11:30 a.m., rapid response called because his oxygen saturation dropped rapidly. Dr. Pham was documented as being at bedside. Richard was intubated. An orogastric tube, OGT, was placed at the time of intubation. 6:19 p.m. Another CBC listed. Hemoglobin 9.2, hematocrit 28.4, platelets 142. So as late as the May 1st CBC documented in the chart, his hemoglobin remained 9.2. Late May 1st, possible first warning of GI bleeding. A medication administration entry contains this very important note. Open quote, cancel note, bloody output from OGT, close quote. The entry is associated with the late evening medication record, and another entry at 10:56 p.m. states that an oral medication was not given because of the patient's condition and that Dr. Pham was advised. This is important because it suggests bloody material coming from the stomach through the OGT may have been recognized on May 1st before midnight. That is earlier than I had previously understood. May 2nd, 2026. The nursing clinical flowsheet documents gastric tube drainage bloody. Again, gastric tube draining bloody. Again, gastric tube drainage bloody. This is one of the strongest findings in the records. There was not simply a vague suspicion of bleeding. The flowsheet repeatedly describes bloody drainage coming from the gastricosh OG tube. Tadak 2:50 a.m. A physician telephone order was entered for. Consult gastroenterologist. Reason, open quote, GI bleed, close quote. The order shows start time 2:50 a.m., read back and verified 2:50 a.m. Submitted by RN Diana Silva Ortega. Priority appears to have been routine. This means that by 2:50 a.m. at the latest, the medical team had recognized a GI bleed strongly enough to order a gastroenterology consultation. What immediately concerns me, at this point, the chart shows bloody OGT output, repeated bloody gastric drainage, GI bleed consultation ordered. Yet the critical CBC demonstrating hemoglobin 3.8 was not collected until approximately 9:13 a.m. That creates a window of approximately 6 hours and 23 minutes from the GI bleed consult order to the CBC collection that showed HGB 3.8. I cannot tell from the extracted records whether another CBC was attempted earlier and failed, whether there was an undocumented result, or whether there was a clinical reason for waiting. But this is exactly the window I would have an expert investigate. Again documented, gastric tube drainage, bloody. Again, gastric tube drainage, bloody. So the bloody gastric drainage apparently continued for hours. Natar 7:01 a.m., a CBC ordered. The CPOE record lists CBC order start 7:01 a.m., submitted 7:02 a.m., acknowledged 7:36 a.m. But the laboratory specimen that ultimately showed HGB 3.8 is documented as collected at 19 a.m. This creates another important question. Open quote, why did approximately 2 hours pass between the 7:01 a.m. CBC order and the 9:13 a.m. collection? Close quote, there may be an explanation. Difficult blood draw, access problems, unstable patient, or a separate specimen, but the chart needs to account for it. In a patient with documented bloody gastric drainage and a known GI bleed, the timing of that CBC could be very important. 8:55 to 9:10 a.m. Richard was in severe shock. Dr. Ricardo Gomez placed a femoral central line for vasoactive medications, CVP monitoring, and blood draws. A femoral arterial line for shock and frequent arterial blood gases. These procedures demonstrate how critically unstable he had become. 9:13 a.m. Critical CBC collected. The CBC specimen was collected at 9:13 a.m. It was received at 9:20 a.m. It resulted at 9:39 a.m. Results: hemoglobin 3.8 grams per deciliter, critically low. Hematocrit 12.9%, critically low. RBC 1.34, platelets 67. Compared with the previous documented CBC, HGB 9.2, 3.8, HTT 28.4, 12.9, platelets 142, 67. That is an extremely dramatic deterioration. The platelet fall may also be relevant because it raises questions about severe sepsis, consumption coagulopathy, dilution, bleeding, or other processes. A specialist would need to determine the cause. 9:15 a.m. Catastrophic metabolic acidosis. An arterial blood gas collected at approximately 9:15 a.m. showed pH 6.979, HCO3 approximately 7.5, base deficit approximately -21.7. A pH below 7.50 represents an extraordinarily severe physiologic crisis. At this point, Richard was not just anemic. He was suffering profound metabolic collapse and shock. 9:39 to 9:41 a.m. At approximately 9:39 a.m., the critical CBC resulted. At 9:40 a.m., blood-related orders appear, including a stat PRBC order. At 9:41 a.m., nursing documentation states, open quote, Dr. Pham advised of HGB 3.8, advised Dr. Gomez has ordered PRBC, close quote. So Dr. Pham was specifically notified of the 3.8 hemoglobin at approximately 9:41 a.m. The physician documentation states, open quote, hemoglobin 3.8 Gardner, close quote, and open quote, transfused 2 units PRBC stat, close quote. Another note states that 2 units of packed red blood cells were ordered stat. That response makes sense once the 3.8 was known. The more important question is, why was the catastrophic anemia not discovered earlier when there had already been hours of documented bloody OGT drainage? Blood bank timing. The records show a blood bank specimen collected at 10:20:55 a.m. received 10:20 a.m. For the first documented PRBC unit, 12 p.m. unit issued. So from critical HGB result around 9:39 a.m. to first documented unit issued at 12 p.m. is approximately 2 hours and 21 minutes. From GI bleed recognized at 2:50 a.m. to first documented unit issued at 12 p.m. is approximately 9 hours and 10 minutes. I want to be careful here. Issued does not necessarily equal transfusion started. There may be separate bedside transfusion administration records, but based on the blood bank record I located, noon is the first documented blood issue time. That distinction should be examined carefully. Number 10:07 a.m., a nursing note states, open quote, Dr. Pham advised that potassium is 6.1 lactic acid 10. Continue current POC, close quote. Richard now had potassium 6.1, lactic acid greater than 10, severe renal deterioration, severe metabolic acidosis, HGB 3.8, actives, suspected GI bleeding, vasopressor-dependent shock. The chart also discusses hyperkalemia treatment with insulin Lokelma and requesting a Quinton catheter for dialysis. Number 10:37 a.m., a repeat ABG showed improvement in pH to approximately 7.237, but he remained critically ill. PASH, noon, 12 p.m. The first documented PRBC unit was issued by the blood bank. Again, I would want the actual nursing transfusion sheet to establish exact transfusion start time, exact completion time, flow rate, whether blood was rapidly infused, whether uncross-matched emergency blood was considered, whether massive transfusion protocol was considered, whether additional units were immediately available. Afternoon deterioration. The records indicate ongoing, multiple vasopressors, kidney failure, hyperkalemia, profound lactic acidosis, severe anemia, GI bleeding. At one point, documentation describes Richard on levofed norepinephrine, phenylephrine neosynephrine, vasopressin, epinephrine. By the time of CPR, the code blue note specifically states he was on 4 pressors. 3:38 p.m. A third documented PRBC unit was issued at 3:38 p.m. The record labels this PRBC Unit 3. This suggests multiple units were being provided, but I would need to reconcile exactly what happened to Unit 2. because the extracted records I reviewed clearly identify Unit 1 and Unit 3 issue information. That is another item I would specifically request from the blood bank. NAR 3:43 p.m. A medication was documented as not given, with the note, open quote, DR fam advised that PT is having GI bleeding, close quote. This is extremely interesting because GI bleeding had already been identified in the chart many hours earlier. We have late May 1, bloody output from OGT, 2:18-2:34 a.m., repeated bloody gastric drainage, 2:50 a.m., GI consult ordered specifically for GI bleed, 6:43 to 6:45 a.m., continued bloody gastric drainage, 9:13 a.m., HGB 3.8 specimen collected, 9:41 a.m., physician advised of HGB 3.8. Physician again advised patient is having GI bleeding. That raises the question, open quote, what happened clinically to address and control the bleeding during those intervening hours? Close quote. Number 5 p.m., Code Blue, Richard became asystolic. Code Blue initiated at 5 p.m. The Code Blue record states, rhythm, asystole, CPR performed, epinephrine, 4 milligrams total documented. Richard was on 4 different pressors during CPR. He remained asystolic throughout resuscitation. 5:13 p.m. CPR was stopped because there was no return of spontaneous circulation. Richard was pronounced dead on May 2nd, 2026. What stands out most to me, Rocio, after going through this again, the period that concerns me actually starts earlier than I originally told you. The strongest sequence I see is hashed late May worst, bloody output from OGT, HEP 2:18 to 2:34 a.m. May ticker repeated documented bloody gastric drainage. 2:50 a.m., GI bleed recognized, gastroenterology consultation ordered. 6:43 to 6:45 a.m., bloody gastric drainage still documented. 7:01 a.m., CBC ordered. 9:13 a.m., CBC finally documented as collected. 9:39 a.m., HGB 3.8/HCT 12.9 results. 9:41 a.m., Dr. Pham notified, 10, blood bank specimen collected. 12 p.m., first documented PRBC unit issued. 3:38 p.m., third PRBC unit issued. 3:40, Dr. Pham again advised, Richard was having GI bleeding. 5 p.m., asystolic cardiac arrest. 5:30 a.m., death. The biggest unanswered question. To me, the most important question is not why they transfused him once they found the 3.8. They did order blood. The much bigger question is, open quote, why did a patient with bloody OGT output documented by late May 1st, repeated bloody gastric drainage beginning at 2:18 a.m., and a formal GI bleed consultation ordered at 2:50 a.m., apparently not have the catastrophic hemoglobin of 3.8 identified until a blood sample collected at 9:13 a.m.? Close quote. And then, open quote, was anything done between approximately 2:18 a.m. and 9:13 a.m. to quantify the blood loss, urgently repeat his hemoglobin, stop the source of bleeding, hold anticoagulation, reverse any coagulopathy, give emergency blood, or obtain an urgent GI intervention? Close quote. Those are the questions I believe an attorney and independent medical expert should focus on. One other issue I would investigate closely is enoxaparin/Lovenox. The medication records show it was part of his regimen and was discontinued on May 2nd. But we need to establish the exact last dose he actually received, when bleeding was first recognized, and when the medication was formally stopped. I do not yet have enough evidence to say they continued administering Lovenox after recognizing active bleeding, but the timing needs to be reconciled. Based on the chart evidence I have now reviewed, the approximately 10:53 p.m. May 1st through noon May 2nd period is the window I would scrutinize most closely, with particular attention to the 2:18 a.m. to 9:13 a.m. interval. That is where the records appear to show repeated evidence of bleeding before the catastrophic anemia was confirmed. I would not tell an attorney simply, they let his hemoglobin drop from 9.2 to 3.8. The stronger, more precise question is, did the hospital recognize objective evidence of an upper GI bleed, but fail to monitor his blood counts and initiate definitive resuscitation quickly enough to detect and respond to massive blood loss before he reached irreversible shock? That is a question these records legitimately raise.